India is characterized by a mixed health system. A system like this, therefore, throws up unique challenges in achieving health system goals and consequently public health system goals, which, like it or not, are common, irrespective of public or private financing and or service provision. These common goals are: 1, improving health; 2, financial protection for the population; and 3 is responsiveness or customer satisfaction. It is imperative, therefore, for a mixed system like ours to leverage the strengths and capacities of its different stakeholders to achieve these goals. COVID-19 presents an opportunity for us to experience, innovate, and adapt, and thereby further identify these strengths and weaknesses of the system at a time when it matters. These experiences must be shared and discussed so that we can learn from them and put the required mechanisms in place to deal with both future as well as the plethora of existing public health issues so as to be able to move population health forward towards a brighter future. I'm excited at the mix of panelists present with us today, spanning the multiple functional domains that constitute the health system, who will be sharing their experiences and insights with us. I hope to be able to provide for our audience today an insightful discussion that stimulates thought, debate, and multiple ideas of innovation and policy reform. So without further ado, I'd like to welcome and introduce our panelists for this evening. Please bear with me, we have 6 great panelists, and I want to do them justice by reading out their brief bios. I'll try to keep it brief. Here we go. Our first panelist is Mr. Kaustav Banerjee, Vice President South Asia and Managing Director for India for Zimmer Biomet. Mr. Kaustav Banerjee is an experienced business leader with a demonstrated history of working in the medical technology industry for more than 23 years. He has previously served as Senior Regional Director South Asia and Southeast Asia for St. Jude Medical, now Abbott. And prior to St. Jude, Kaustav worked for Medtronic for 6 years, where he held various finance and operations positions. Kaustav is also a board member in the Medical Technology Association of India and an executive committee member of the Advanced Medical Technology Association in India. Welcome, Mr. Banerjee. Our second panelist is Dr. Sajjan Rajpurohit. Dr. Rajpurohit is a medical oncologist in Max Multi-Specialty Center, Vaishali and Noida. He has more than 10 years of experience in this field. He is an MBBS and an MD in medicine from Maulana Azad Medical College and a DNB in medical oncology from the Rajiv Gandhi Cancer Institute. Also recipient of the Young Scientist Award and the Dr. Satya Gupta Memorial Award for the Best Thesis in 2017 by the IAP. Our third panelist is Mr. Manoj Kumar, Senior Vice President with Intas Pharmaceuticals Ltd, and is responsible for biopharmaceutical units including oncology and transplant. He has close to 23 years of pharmaceutical industry experience in organizations of repute such as Intas, Novartis, and AstraZeneca. Under his leadership, not only has the pharma fractionation unit tripled its production, but Intas has also in this time emerged as a leading global company in the super specialty space. Our fourth panelist this evening is Mr. Sachin Saxena. Sachin is the Director of Marketing and founding team member at Innovesa, a leading healthcare technology company based out of San Francisco. In his role, he has been instrumental in accelerating the company's vision and mission and helping providers, payers, and other health organizations deliver excellent quality of care and better patient outcomes, all at a lower cost. Gartner recently cited Innovesa's marketing strategy as a case study for health tech organizations across the world. His unparalleled vision and strategic insights have also played a role in getting Innovesa recognized as North America's fastest growing companies in Deloitte's 2019 Technology Fast 500 and other big accolades such as this. Our fifth panelist is Mr. Sanjay Sonar. Sanjay is an experienced hands-on solution architect and subject matter expert involved in the architecture, design, and implementation of traceability solutions for the pharma, agro, and food and beverages industry. He has been in the business process automation industry since 2010. Sanjay is currently working as a subject matter expert for product traceability at the Optel Group. helping many global Fortune 500 companies in the implementation of cutting-edge supply chain traceability platforms and solutions. He's a technology evangelist with vast experience in end-to-end product traceability technology and its functionalities. And finally, we have Mr. Varun Zhaveri. Varun is currently deputed as an officer on special duty at the National Health Authority, Government of India. He leads the innovation strategy and focuses on supply-side strengthening at the NHA. He has worked with the Asian Development Bank, the United Nations, Niti Aayog, and the University of Chicago. Earlier, he has been the youngest person to chair the UNESCO's Youth Council for 3 years and has been an SDG goalkeeper for the Bill and Melinda Gates Foundation. So that's our panel this evening, a beautiful mix of perspectives with lots of experience, lots of innovation, lots of ideas. And I'm excited to get into this. Thank you once again for joining us, both to the panelists and to our many participants who I can see are now all online. I want to jump straight into this discussion. First, I'd like to come to you, Dr. Raj Purohit. You work at the Max Super Specialty Hospital. And we've seen that Max, it's a big corporate hospital, and one of the big focuses has been to ensure that patients like yours, cancer patients, and other patients in need, with life-threatening conditions, get their essential health services without interruption. In a way that's convenient to them, and also addressing their fears about catching infection and things like that. Could you throw some light for us on how really Max went about, doing this during these times, and how it was able to reach its patients? Over to you.
I think such a valid question it is here, and so the strategy began with the COVID pandemic being declared in India, and at first we knew that private sector definitely will start playing a very important role, especially when the cases were started increasing. So what we did at the first go was that we dedicated 2 of our hospitals who were big hospitals. So they had east and west towers. And then we made one part of the whole hospital, which actually was not a block, but it was a separate hospital itself. And they were designated as COVID hospitals. The first thing which Max did was to label, for example, we had Max Saket facility, and that had east and west towers. So one whole tower was dedicated at the beginning of the pandemic to become a designated COVID hospital. Similar way, we had another of our hospital, which was Max Parpaganj, that also had a dedicated tower, which was converted into a COVID hospital. So that was the first phase in which some of the facilities of Max were converted into COVID hospitals. But over time, over next 3 months, we found that the cases were actually increasing, and there was a lot of overflow which was happening from the government organizations. People were coming to the private sector. They were seeking relief in the private sector, and they wanted to have treatment in the private sector, and our beds were getting short. So there was a revision in the policies, and now almost all our facilities have designated COVID wards, and the previous hospitals continue to be operationals, but at the same time, among the 13 hospitals which we have of the total Max group, almost all the bigger hospitals, they have dedicated COVID wards, COVID ICU, and a channel which actually only works for the treatment of COVID patients. So the hospital management took very quick decisions, and they increased the capacity to handle COVID patients. At the same time, we also ensured that the other patients who required emergency and semi-emergency medical conditions were not shown the door off, and they were not returned back to the society. So their care was also continued during this time, and we have been able to manage it really well, and patients have been coming. For example, oncology patients, there was initial fear, but over the last 2 to 4 months, they've again started coming back, and they are taking treatment without the fear of getting COVID from the hospital.
Yeah, you're muted.
Thank you. Sorry about that. Thank you for that response, and I'll come back to you because I do want a few more insights on, the level of preparedness and how fast hospitals were able to jump in. But I'd just like to take it now to Mr. Banerjee. Mr. Banerjee, I know that for the med device industry as well, there were great, efforts in ensuring an uninterrupted supply chain, basically. And I'd like you to kind of highlight for us what were the struggles and really what was done to ensure that your patients as well were, you could bring value to your patients in the midst of serious liquidity challenges as well, as, I'm sure there must have been for you. So could you kind of, give us some insights into that?
Yeah, first of all, thanks for inviting me into this panel. Thank you very much. So if you look at the challenges, first let us understand the challenge for the ecosystems has faced. Then we can move on to the medtech industry specifically. See, in India, we were all geared up, or rather globally, we were all geared up to deal with lifestyle disease. And as you know, all the agency reports over the last 10, 15, 20 years have been talking about moving from a dual burden of communicable and non-communicable disease to how to manage more about, our research are focused on managing non-communicable disease, more importantly, lifestyle diseases. Now, this COVID has kind of proven all of us wrong and built a huge stress on the entire system. And that got exposed not only in India, even in developed countries in the West. But there are certain challenges that we faced. First, if I look at the challenges, we have to divide it as the initial set of challenges and the challenges we are facing now when there's a little bit of awareness, and subsequently what we are going to face in future and as we anticipate. The first challenge was even to make the basic movement possible. The elective surgery, or even there are a lot of elective surgery, who are patients in serious condition. The mobility was restricted, and as you know, India, large part of the population come for treatment from the tier 2, especially on the tertiary care, tier 2 to the metropolitan cities. The borders were blocked. It was a huge challenge even for the patient and their kith and kin to move. That was also a similar challenge that we faced in the medtech. More importantly in orthopedic, because on orthopedic, what happened? Orthopedic was never treated as an essential service among the all the other specialties. So even we got challenges in terms of getting our passes of moving our people to effect the supply. Second thing that we experienced as we move on was the hospitals were occupied largely by mandates to manage COVID patients. As a result, there were a huge shortage of physicians and nurses, because they were also getting infected. That created a clear stress on the entire hospital and the provider system. Next is the challenge that we faced with the patient perception. Patients were not willing to step into hospital. So people who were scheduled for elective surgery, they cancelled. Eventually, those patients who had scheduled surgeries, they started coming back. But the OPD footfall still continues to be low in most of the functions within the hospital. When we see most of the super specialty, the OPD footfall is very, very low. As a result, the entire provider comes under tremendous stress. And because provider come under stress, we in the end of this part of the value chain being medtech or the pharma companies, we also come under stress. Because ultimately, if patient don't get treated, there is no need for supplies, and there's no need for supplies, there is not much we can do. But at the same time, we also had an obligation to make sure that whatever patient who comes in and gets admitted to hospital, their safety was of primary concern, both for the provider as well as the medtech company. So we ensured that a lot of focus is paid on patient safety, and that is across the care continuum, whether it is preoperative, interoperative, or postoperative. Second was making sure the supply chain is uninterrupted. And keeping supply chain uninterrupted at one point in time was a major challenge because of domestic distribution trouble we had, and also the international freight movement, not only in terms of cost, which went up by 5 times, but also in terms of availability of flights. Most of the flights were cancelled, and there was a very skeleton structure run by the the global forwarders. As a result, we had a tremendous challenge in moving things. And also we faced a huge amount of challenge beyond liquidity. I would say there is a cost that made it very difficult, and sustainability at times was a major concern for most of the medtech companies, because the operating costs went up, including the cost of managing a whole load of resources with a very utilized and very low productivity. Orthopedics especially has a challenge of maintaining instruments with the hospital. In a sense, for every surgery that it gets done, the company had to provide all the instruments for the surgery. And because of the low surgery volume, there was a large cost of transporting those instruments. At the same time, the utilization of those assets were very low. Plus, maintaining the entire workforce, ensuring the OT support, because orthopedics also has a requirement of providing in OT support. When you do a procedure, there has to be a company representative or somebody from the supply chain or the distribution has to be present to extend support with the instruments, and also at times they are a critical resource in the entire process. So all that collectively, and their movement was a challenge. Many of them were not getting passes, but that is something we could overcome now. Right now, if you look at the challenge is ensuring that how do we give patients the confidence to come to hospital, get treated, get themselves diagnosed, assessed, and whoever needs different treatments can go and get the surgery done. As of today, if I can tell you, the orthopedic industry and like many other elective processes have faced like 85 to 90% decline in the volume of surgery that happens. So it's a huge stress. It's a huge stress, and definitely because of all this, liquidity comes under challenge. Because when you have low sales volume, high operating cost, it's like a very difficult situation to handle. But having said that, we are gradually getting back and recovering, but the pace of recovery is not as fast as we would expect.
Right. Thank you, Mr. Banerjee. Manoj, I'd like to take this to you because I know that you have related issues. Within pharma, you've kind of also experienced something very similar, and I know Intas has also tried to do something to circumvent these wherever possible. Can you give us some ways and means in which you've also tried to sort of address your supply chain issues? You and of course across the pharma sector, what experiences you can share with us?
A couple of things that I would share happened to my company, and a couple of it with a couple of other companies. I think pharma realized it quite well in advance that there is going to be a challenge. And please understand that first COVID affected the world in the third week of December. And slowly and gradually, we realized that the world is not going to be the same. First challenge is a lot of manufacturing APIs are actually from China. And the second one is Europe. And we knew that in January and February, most of the API unit needs to be shifted from China to either in-house production or a couple of other places, or collaborate with those companies which has got this bandwidth, so that whether COVID or no COVID, neuropsychiatry challenges will not die in India. Diabetes will not die in India. Cardiovascular disease will not die in India. There are a lot of disease which is still chronic. So we and many other pharmaceutical companies first prepared for the existing demand which is already there, ensuring that API is in place, formulations are in place, or those products which are very small therapeutic window, we collaborate among each other so that whatever is the existing need is catered. I think I'll be positive when we say that the entire pharmaceutical industry has done a wonderful job, that even in this tough time, most of the chronic supplies, not just of Intas, but most of the other companies were also there, either by delivery mechanism or either by ensuring that you cover half the distance, the other guy covers half the distance. So, we saw a lot of collaboration during this situation. At the same time, we also realized that there will be a need for a lot of drugs which we never, or we kept it in the cold basket. For example, before COVID, nobody thought HCQ would be important. Dr. Sajjan would know it. We tocilizumab or remdesivir. I think there were, or plasma therapy, or for example, interferon. There were so many drugs which were hardly in use, and suddenly, these were the drugs which started getting initially to begin with experimental uses, and then realizing that probably it is working. Please don't forget that still the death rate is one of the lowest in India. I think it is 2.5%. And somewhere down the line, the healthcare fraternity and the pharmaceutical industry realized and took a proactive decision. There were challenges. It took us some setbacks to realize that what has hit us. Please remember when the first Janta Hartal took place, or that was on 21st of March, and the total number of cases was close to 400. And today we are having close to 7 lakh or 8 lakh. But at the same time, now we realize that COVID is something which is threatening. At the same time, 98% of the people come out of it. We ensured that those who need the medicine still have it. And at the same time, we are preparing for future. For example, there was just one company preparing remdesivir, and going forward by July, there will be 5-6 companies preparing the same products. Plasma therapy is something which is being worked out. I have never seen such an active interest into vaccinations that we see now for COVID and also for other therapies. The awareness level for healthcare suddenly has started going up. People have realized that instead of shopping for something which is a lifestyle thing, let's shop for those products which are immunoboosters. Suddenly, people realize that whether it is just about life, and it is not just homeopathy or Ayurvedic or allopathic treatment. It could be a management mix of all the three or multiple modalities. So you suddenly see Giloy being used, you see Ashwagandha being used, and many propagators of a mixed therapy or a holistic therapy is also coming up. I would say the time was tough and the time is still tough, but because of proactive measures by government, by healthcare industry, by healthcare professionals, we still have been able to avert what could have been a catastrophe.
Thanks. Yeah, I think what you're saying about the emphasis on health, I think that's one of the, despite everything the system has gone through, I think for those who've been working in the sector for long, and especially in public health, one of the good things is that finally health hopefully will get the attention it deserves. And I think that's one of the things also, when I talked about that, that spending to recover from the effects of a public health crisis, 10% of GDP versus the 1% that we spend on health as a sector, public money, really it's a thing that we've been asking for a long time. And of course there are justified reasons why spending has remained at the level it has. But it's definitely a point in time where we need to relook at priorities and really where the investments need to go. Since we were talking about these issues of supply chain and keeping the supply chain going, which was one of the biggest challenges for both pharma devices and across sectors, I'd just like to bring in Sanjay here. Because Sanjay, you work in this area, you work in intelligent supply chain solutions. Can you tell us, basically give us an idea really of what your track and trace solutions are and what you do, and their potential role really in revamping the model of these globally connected supply chains that we now understand so much more about, in their current form? How can these solutions really revamp this model?
Yeah. So Kia, first of all, what we have experienced in last 6 months is that this COVID-19 has in fact disrupted every supply chain around the world, not only India or not only China. In fact, from food to healthcare, medical devices, PPE, ventilators, everything. global shortages has actually highlighted the supply chain failure in many dimensions. Now, of course, we don't have any medicine or vaccine for COVID-19 yet, but still we have realized that there has been shortages reported for common medicines like painkillers and maybe medicines for diabetes and hypertension, because the focus of the pharma industry has been to cater to the medicines that are relevant in this COVID situation. So that way it has also affected other medicines which still remains relevant even if we are in this COVID situation. Now, all this has actually emphasized that the need for globally connected supply chain system is now clear than ever before. And also, COVID-19, in fact, could be an black swan event that finally forces many companies and many industries to rethink and transform their supply chain model. Now, when we say that the supply chain has to be transformed or has to be rethinked, then a word which very frequently comes in our mind since the last 10 decades we have been talking about this is intelligent supply chain. So what in fact is an intelligent supply chain? So intelligent supply chain is basically transformation of the conventional supply chain into a digital supply chain by re-imaging of various processes and infusing them with intelligent technologies, which we have been already uh, implementing at various stages or maybe various other places than the supply chain management. So basically ISC connects people and processes and things so that it enables visibility, it enables communication among various supply chain players. And at the end, it enables planning, it enables analysis, and it enables a proper execution of supply chain operation. And if you see, all this sounds very good and sounds very good to have. So why don't we have it yet would be a question. And what are the real benefits could be another question. Now, if you see today, we already have good traceability technologies. If we want to book a cab, for example, suppose I need a cab, I can just go to an Uber or an Ola app and I can see if there is a cab around my location and I can book that cab and the cab will be in my place in fraction of minutes maybe. But today, if I need a ventilator, if I need a PP consignment, if I need some critical medicine, then I don't know where it is. I actually have to follow my traditional paper-based supply chain processes to source it, to find it, and to get it. So the technology is already there. We have been using IoT technology. We have been using advanced analytics and digital intelligence technology, blockchain technology, everywhere else. But we have never thought of using these technologies in the supply chain. And that is why this COVID-19 situation actually makes many industry and many companies to rethink that whether investing in these technologies for supply chain optimization is actually an investment which is relevant, or it is actually something which is essential. Now, if you see the benefits of ISC intelligent supply chain, I can go on and on, in fact, from raw material traceability to asset management to warehouse automation and so on.
I think that Sanjay, that gives us quite a an insight, and that's really helpful. Also, I think that's a good way to look at really tech solutions. Like you said, the technology is there. We probably haven't been using it. I'd like to come back to you and also talk to you about what are the cost implications of this technology, right? I mean, if it's there, obviously, that would be one of the reasons, and I'd like to discuss that further. But before that, if I could move on to Sachin. Sachin, you are data-driven tech. That's your thing. And I know you guys have done a lot of work during this time, during COVID. You've come up with, with solutions, with innovations for the public system. There were also some partnerships with state governments. Can you tell us what your company has done? What are some of those innovations you've done, and really how you've been able to contribute to management of COVID?
So first of all, thank you for inviting me for this great panel discussion. For a start, the reality is that we are witnessing 10 years of a change in a single 1 week. COVID-19 is actually the catalyst to that change that we could have experienced a decade from now. Like technology is actually now driving life in the time of COVID-19, where social distancing, lockdown are actually very important. Or tablets, where like technology is actually bearing a lot of weight of information management, governance, and actually helping us inside our homes. As a digital health company, honestly, like we are actually seeing the kind of a change in a technology, especially like in the India segment, when we worked with the Goa state government, like in 24 hours, we actually launched the self-triaging application. Within 24 hours of launching the application, 150,000 users actually downloaded the application and used the application to check whether they are COVID uh, high risk patient or a medium risk patient or a low risk patient. So, like a lot of time, like we generally worked with the US state government and US healthcare systems, but the kind of change we are seeing, like at the time of COVID in India, is actually tremendous. Like we work with Pondicherry government and one or two more state government, we are seeing like how basically like the state government and private sector coming together and actually trying to solve a few of the biggest problem we are facing right now. At Innovator, particularly, we actually understood the pain point of doctors, medical staff, and patient, and our actually mission is to support the healthcare stakeholder to work care as one to achieve what we actually designed, like India's first self-assessment app and virtual care enabling solution. Like actually, where you can see like a lot of doctors can see their patients from their home, where actually patient can also see like to the doctor, like they don't need to go to the hospital actually come into their home. And like this is in the US kind of a states, we can see the 4,000% greater than the telemedicine visit comparative to the last year. So that is itself explained like in terms of number how basically the entire world is changing in terms of technology, in terms of like the entire data driven space in general.
Right. Thanks, Sachin. Yeah, I think that really gives us, the role of technology across, like you said, it's not about, you developed apps, also your teleconsultation products. And I think teleconsultation is another big area that we've sort of suddenly realized is out there, which we need to explore a lot more. And it's not something that's actually really only relevant in the times of COVID, right? Because we have accessibility issues for rural, populations for decades now, and for issues of public health concern, which are not just emergency infectious disease outbreaks. So I think these are some of the things that hopefully we look at more seriously in the days to come for all kinds of problems that we need to address as a system. So I'll come back to you about that. I'd like to bring in Varun now. Varun, you work with NHA, and you guys have been implementing Ayushman Bharat PMJ now for a while. And as part of this, Varun, I just remind you to unmute yourself. Yeah. So you have the experience of really working with private sector for a while now. And so from the perspective of public engagement with private sector, one of the things you guys did was to introduce COVID treatment in the health benefits package, both testing and treatment during this time for your beneficiaries. Can you tell us, how easy was it to do that? How did you go about the price setting? Did you deal with empaneled providers, existing empaneled providers? Did states have to go and empanel additional hospitals to be able to roll out the package? What was the uptake like? Give us a sense of this process of engagement that you underwent, and what were some of the strengths and challenges there?
Yeah. Firstly, thank you, Kia, for inviting me. It was great hearing some of the nuanced insights from the other experts. Since I work with the government, I need to make a disclosure that I will be speaking in my personal capacity today. Uh, as you mentioned that, at NHA, we manage the Ayushman Bharat program. And, since last 20, 21 months, since the time we have been implementing the scheme, we have been extensively working with the private stakeholders. As a matter of fact, the 23,000 hospitals that are impaneled within our scheme, almost half of them are actually private hospitals. So you can see how much important is the private sector participation in the whole scheme. Now with the onset of the COVID, the first and the foremost decision that we took was that all the Ayushman Bharat beneficiaries, which is almost 40% of India's population, somewhere around 55 crore citizens, uh, we took a decision of ensuring free treatment as well as free testing in any of the Ayushman Bharat impaneled, hospitals or any particular facility which is impaneled by us. As a matter of fact, what happened was that we ensured that the lack of finance, it does not become a constraint for any of our beneficiary to not go out there and get their testing or get their treatment done. At the same time, what we started doing was we started an expedited empanelment of hospitals. So if you look at, right from April 1st, we have empaneled, close to 2,000 new hospitals, in the already big pool of hospitals which were empaneled with us. The second key decision that we took was we directly started empaneling private labs for COVID testing particularly. So, the overall capacity in both the testing as well as treatment, we drastically augmented that. At the same time, there were various other things that we, took on, such as, first of all, we were manning the 105 national helpline for COVID. The second was that, all the high risk beneficiaries within the PMJY beneficiary pool, we were calling them and we were trying to, see if they have any particular symptoms. And we were constantly monitoring what is the type of outbreak of, COVID related symptoms, COVID like symptoms like SARI, ILI, pneumonia, because in the initial days, it is really tough to gauge that. The third thing that, a lot of Indians, we were using Arogya Setu app. So, folks who were at the moderate level of the risk or at the high level of the risk, we were calling them to actually understand if they need, some form of a testing or if they need some form of a consultation from doctor. So that was also a helpline that we were manning. At the same time, to your question with regard to how the process went on, I think, there were two different pathways. With regard to the treatment, we gave a flexibility to the states to actually come up with the package rates which are which the states are compatible with, because we have through the experience that we have seen is that the states, they have a good idea with regard to some of the existing costs which are there in that particular state, and it also differs from state to state. So rather than us suggesting a fixed amount, we gave that particular flexibility to the state to design a few package rates and let us know about what is that particular compatibility that they have. The second thing that we did was that ICMR had already come up with a ceiling of a testing rate, which was the 4,500 at that point of time. So we adopted the similar ceiling of that particular testing rate, but we also gave the flexibility of the states to decrease it if they want, depending on the requirement. And we saw that a lot of states did actually, decrease that particular rate depending on the discovered rate that, they have in the state. At the same time, one thing that we were experiencing was, of course, that because of the lockdown, the uptake or the utilization of the services, that was definitely decreased because, because of the lack of mobility. A lot of hospitals, either they were not functioning or, they were converted to the COVID unit. So there was a slump in the utilization. But what we ensured was that, because the normal utilization which is still there, which is regard to things like dialysis or chemotherapy or any of those particular treatment, that was still very much there. But the hospitals or the supplies, the supply side, it wasn't available in the large number that it should be. So we started even empaneling such type of units. Like we started empaneling, units for providing dialysis. We rolled out a new technology which had a bit of relaxed empanelment criteria, so that we can empanel more and more hospitals and more facilities. So in and all, as several of the panelists have said, I think it was a very holistic response where we were trying to focus on both the components, the patient as well as the providers. We were informing the patient, we were trying to track if there are any particular symptoms, we were trying to help them through the manning of the COVID helplines. And at the same time, with regard to the providers, we are trying to empanel more and more providers. We are trying to set up package rates. We are trying to empanel more labs. So and this has only been possible with the with the type of participation that we have got from the private sector. So I think as of now, I would say that it's been a good start in terms of the COVID response. But of course, there are many more things to come.
Right. Yeah, thanks, Varun. It's good that we at least have that, some level of engagement through Ayushman Bharat, so we can get insights, because otherwise there is definitely like, a legacy of trust deficits, and issues wherein, one side has apprehensions about working with the other side. And I keep coming back to what I said about the mixed health system. The reality is we are a mixed health system, and we have strengths within different components of the system. So unless we sort of work through these issues, and you said you left it to the states to decide on the cost of treatment, but I guess we would have to look at how states have dealt with that, because even for Ayushman Bharat previously, there were a lot of issues around the costing of the packages, and then there was a revision, in the second version of the benefits package and prices, and this has been an issue, and I'm sure it will continue to be an issue. So just coming to this cost issue, I think I would like to sort of take it to other panelists as well. Mr. Banerjee, if you can come in and tell me, because this is also an issue with the device sector. The device is also now coming under price controls, and this was an issue before. And in the context of COVID also, there have been dialogues, the ministry through the NPPA, making sure that prices of essential commodities don't rise above a certain amount. What are really the contentions on both sides, and how does it differ during an emergency situation? The concerns are different, and during business as usual also the concerns may be different. So can you give us a both sides perspective of what these issues are, and how best you see it as being able to kind of go beyond this problem with the price controls on devices?
Yeah, that's a very interesting subject, and I think if you really talk to most of the global innovators, everybody would recognize that price control per se is an archaic method of controlling a product, because the way we need to look at, we have to understand the problem where it exists. And if we continuously work towards price control, we will throttle innovation, and we will also keep novel innovative technology introduction in the country. And we will go 15, 10, 20 years back. Because if you see 20 years back, when a device was launched in the US, it used to come to India after 5 to 6 years, but that's no more the case. Provided we move into something called trade margin control. If we have to really understand, the problem lies not in the price, it lies in the trade margin. As long as the trade margin is controlled, what we require is, first let us understand whether we need to harness global supply chain. If you have to harness global supply chain, two things are essential. One is creating a regulatory environment which is harmonized with global regulations, and not create India-specific regulations, because that becomes a big, very large barrier to harnessing global supply chain capabilities. Second thing is that when we look at price control, the better way of, innovation comes with a lot of research cost, and any company who had done basic research would look for recovery of their cost. And behind every successful research, there may be 10 failed research which we don't understand. So if we go and look at the whole healthcare spectrum, the way we look at brick and mortar technologies, it would be very, very difficult. So what we require is a rationalized regulation or reimbursement system which relies on health technology assessment. And what does health technology assessment does? It basically relies on basic principles of health economics and outcome research. So one is evidence and definitely the incremental cost. Another thing we need to also understand in this context, there are two ways of looking at cost on the health system. One is an episodic cost on the health system. The other is the overall burden on the health system. You may deal with a problem today and there can be recurrence 10 times later. So the overall cost on the health system, which will make the payers bleed, whether it is government or an insurance company, if the overall cost is higher. So we need to focus on disease management cost versus an episodic cost. So I am a proponent of trade margin control versus a price control. And I believe today I represent the Medical Technology Association in several communication, and over a period of for more than 2 years, Niti Aayog as well as NPPA recognizes this. And that was one of the reasons we saw the first trade margin control came into oncology drugs. And according to Niti Aayog, that is quite successful. They have been able to bring down the cost of oncology drugs significantly. Second is
I think we've lost.
incentivized is to look at trade margin control versus a price control. Because price control, if you look at medical technology, prices have on its own, because of market forces, kept coming down over the period of last 5 years. Tell me one device where the prices have gone up. Maybe the patient may be paying more. That's a different story altogether. But devices prices have never gone up.
Right. That's really interesting, Mr. Banerjee. Thank you for that perspective and the whole, the explanation of trade margins and looking at the nuance of what really we're trying to control and look at it from a system perspective. Also, the health technology assessment, which I agree is something that's really important, which we have to start looking at. Every time we roll out a program, I think that's one thing we miss out and there have been conversations about that. There was supposed to be an MTAP set up in the DHR. I'm sure it's something that NHA is also looking at eventually introducing. But thank you for that perspective. And Mr. Kumar, would you have anything to add to what Mr. Banerjee said? Because you also pharmaceuticals also have this issue and have faced this issue for a while. Do you have the same perspective or do you have a different take on this? Can you share with us some of your thoughts?
So I'm a propagator of correct pricing. And I think India, we are lucky that we don't have just one product, but we have a plethora of products. Dr. Sajjan would agree with me that you also have innovators and you also have the biosimilar version of the innovators. And if those biosimilars or branded generic versions would not have been there, many of us would not have been alive today. The very longevity of Indian population has been because of so many products available, and the physicians and clinicians have an options to choose from. At the same time, there are drugs which are essentials, which are life-saving, and I respect the decision of Government of India last year when they brought in those drugs under pricing control. But I have also seen that government was cautious that they supported the research and development. For example, I have not seen much price control on those immuno-oncology drugs. They were innovators and they had just been launched. There has not been a price control, but there were products which were 10 years, 15 years, 25 years, and they would have served. So somewhere down the line, these have ensured. At the same time, governments have also pitched in. There are various government schemes, not just for cancer care, but various other critical cares. So there has been a public-private partnership, and all of us, whether pharmaceutical industry or whether governments, have chipped in with their bit. Even in hospital setting, I see various different kind of treatment modalities. One who are living out of pocket, one who are into the reimbursed categories, and the treatments are customized to them. So I would say that These things are essential to bring in a harmony in such a disharmonized country like ours.
Okay, thanks, Mr. Kumar. That's very interesting.
Just to give you a perspective.
Exactly. No, that's the great part, because I see that always when we have people who you would think would have similar sort of takes on something which sometimes seems so black and white to some people, but it's not. There's a level of nuance that that needs to be understood, and I'm glad the students can kind of weigh on this. And just a reminder to the audience that please post your questions in the Q&A section, because we'd really like to take some audience questions towards the end of the discussion. We'll take as many as we can, but please post your questions in the Q&A section of the discussion. On this issue, Dr. Raj Purohit, you deal with cancer, which is an illness that is a high cost illness in terms of treatment, but it is a significant public health problem. India has been dealing with the double burden of disease very significantly for some time now, and this is just set to get worse because our burden of non-communicable diseases is increasing. We have in the public sector introduced some level of screening programs. It's supposed to be part of the first pillar of Ayushman Bharat as well, for early detection of cancers. But access to treatment within this public sector is still limited, and private sector plays a huge role there. Can you highlight potential areas for partnership that we should really be looking at in terms of engaging, so that more people can have access to treatment, while also in some way making it affordable treatment? What are some areas in which we can work on?
So we saw during this COVID time that government has actually engaged private sector into the management of a pandemic like situation. And after 3 months, 4 months, we are much better. So I think a thoughtful involvement of the private sector to the cancer management also is very vital. And I think there needs to be more participation in both the public and private partnership, because there is a huge divide. So if I tell you very honestly, most of the cancer treatment which is being offered in the private sector, and now we have got a very good organized oncology setup in many of the bigger corporate hospitals. And I can assure you that amongst the private sector, we are able to offer treatments which are world class. You'd be surprised that even the leading cancer institutes, and in fact, Mr. Kumar will agree that amongst all leading cancer institutes worldwide, our rate of detection, the pace of diagnosis, treatment is really rapid, and patients get world-class treatment in most of the private organizations as of now, which have a comprehensive cancer institute. Also, we have certain sectors in the government, like Tata Institute, as well as All India Institute of Medical Sciences, and many of the regional cancer centers, which are doing reasonably well, which are, I would say, with the patient load, they are doing commendable work. But then there needs to be much more empowerment of the government sector, and there could be a public-private partnership where they could actually have expertise of the doctors, of the medical staff who are working in the private sector, engage them in a manner there where the kind of care which we expect for our patients is able to reach to majority of patients. In fact, even today, 90% of our population has access to suboptimal cancer care treatment. In fact, in many of the government organizations, even if they have facilities, patients are waiting for 4 to 5 months for radiation to happen to them. And surgeries, the surgery waiting time can be as far as 6 to 12 months. So this is not acceptable in a disease like cancer. So I think once we are over with this COVID era, we'll have learnings from the COVID situation as such. And I'm very hopeful that government will also have keenness, and we have Varun from the government, and they will actually have this understanding that for cancer we need to do more than what we are doing as of now. With respect to the price control, I think all the doctors as well as the patients are very happy, because more patients are able to get treatment, and I think that's a very welcome move. At the same time, I also understand Mr. Costo as well as Manoj explained that there are certain drugs which will be costly because they are innovators, and we all understand that not all drugs can be made affordable and populism cannot work for all cancer drugs. So I think there is a way to go when we deal with cancer patients, and there's also a need once we are beyond COVID and we take these learnings from this COVID pandemic dealing and we go into a more inclusive private sector engagement. We understand where is the how is the path forward, where we could actually have facilities as well as the expertise and go hand in hand with the government to make cancer more affordable, more manageable, and more curable.
Thank you. Thanks, Dr. Raj Purohit. I'd just like to move this in a slightly different area now, which is, our information and data. Sachin, I'd like to ask you, your experience really has been largely in the US market, and there, you have provider networks, you have payers. So, the information to some extent can be harnessed and can be converted into useful information. The data can be converted into useful information to monitor patient outcomes and things like that, and important information for payers and providers. Now, in India's health system, which is more fragmented in that sense, there is still a large scope for digitization of data and eventual information-based technologies. What do you think are some of the important areas where these technologies can be incorporated, and how within the Indian market, and what would be some of the facilitating factors to make that happen?
Definitely. So, like in case of US, the most important thing what they started 10 years back is the electronic medical record, what India don't have today. Like this is very, very important. Definitely, like Varun is also one of the panelists, and in India, we are taking a lot of initiative towards that. But actually, EMR is the most important component to actually working together in terms of payer, in terms of employer, in terms of private companies, along with healthcare, hospitals, and health systems. Like it's very important whether you are tracking any patient just like a bank record. Like if you really want to see what transaction you did 5 years back in your bank account, you can see very easily. We are like in terms of healthcare, if you really want to see what kind of medicines actually prescribed like 3 years back to you, it's really next to possible in India, where it's very much possible like in the US. So it's very important like how basically we are implementing the EMR kind of a technology in India first, and then we can see how basically we can work together as a one. And it's like beneficial for everyone. It's not like for payer, it's not for government. And that's why like in US, government and private sector are actually working very, very closely to each other. There is a kind of an incentive model what government roll out to the private sector as well. If even private hospital is working on some of the metrics what are really working well, they are actually granting a lot of money from government. So it's very, very important like how basically we can see the entire thing of digitization. Like once you have data, then it's very simple how basically you are integrating the entire patient data, how you are seeing the patient 360-degree view, where you can analyze and also do a lot of risk prediction, like whether this person is going to be a cancer kind of a disease or not. It's all data driven. Like in India, it's really tough if you really want to do data analytics. We don't have actually the structured data. And if you don't have a structured data, it's next to impossible to actually do the kind of analytics to predict the risks, like what kind of a disease you have to do like next 6 months. It's really tough to get it.
Right. Yeah. So exactly, and I think Varun, if you can, come in here, addressing what Sachin was saying also. But now we're looking at the National Digital Health Blueprint as well. That's been out, and that's something that you guys are working on and propagating. Where do you think we're at now, and how much further do we need to go to really improve our digital health systems and really be able to use data to monitor patient outcomes, to also look at our provider networks, like now within PMJ we have it's kind of having, and your empaneled providers are sort of they're not a network per se, but it's a way into looking at, there's a lot of information that gets collected, a lot of data that gets generated that we can use to improve scheme, to monitor outcomes and to make changes, monitor contracts and panel contracts. So where do you think we are at, and how far do we need to go? What's the potential in this area?
Yeah, thank you for that question, Kia. Before I give my inputs on that, one particular comment, to the follow-up response that you had on the COVID package prices. When I said that the states have been given the flexibility, I meant the states have been given the flexibility to finalize. We have given, some sort of a draft package rates based on our understanding and our, calculation, but it's finally up to the states who are finalizing this package rates. This is unlike the normal PMJY package rates, where states, can't have that much, leverage in terms of finalizing a particular package rate. So this is, there's a very, different scenario as compared to PMJY versus COVID. So that was one particular, comment. With regard to data, of course, I think from day one, PMJY, I will first come to PMJY and then I will come to NDHM. In terms of PMJY, I think from day one, we have been one of those schemes which has been, strongly advocating the database decision making. Now, when you look at PMJY, the entire system, starting from, the beneficiary, checking whether he or she is present in the database, till the time, the beneficiary is taking out treatment and getting discharged, everything happens on a digital platform. So, naturally, there is a lot of data which comes to us in terms of, what are some of the, some of the trends. Now, we have very granular based monitoring and evaluation, wherein not only till the state, not only till the district, but even till the very hospital level, we are able to monitor what is the type of performance, what is the type of utilization, specialty wise, procedure wise, and to see even things like, if a patient from district A is going to district B to actually avail the benefits, to see what is the type of intrastate and interstate portability which is happening. So I think, in terms of the PMJY, and a lot of decisions that actually happen, or rather every decision which happens, including reviewing the progress of the states, happens through a very, robust database decision making. And this is the reason, the main reason behind this is because we are getting a very structured data, especially in terms of the patient registration, utilization, discharge, claim uploading, claim reimbursement, what is the time which was required to pay the claim. So, if you look at the overall system, PMJY, there is a lot of monitoring and evaluation which is taking place. But as some of the other panelists were mentioning, that there is also a very important need for now going towards the next step of revolutionizing the entire health ecosystem and using and leveraging technology to cultivate a digital health ecosystem. And that is where I think we are at right now, based on the National Digital Health Blueprint, which was adopted sometime last year. There is already some sort of a work which is started on the lines of a national digital health mission. And it is a very interesting prospect, not only for hospitals, but for the entire country, because it includes providers, it includes doctors, it includes citizens, and a lot of technology components such as EMR, registries, citizens ID, all those different components will actually get created as a core building blocks of the National Digital Health Mission. So, I would not spill a lot of beans right now because a lot of work is in progress. But let me assure you that, in upcoming few months, there is going to be a lot of progress which is going to happen through this. And, it is going to completely revamp and revolutionize the way the healthcare is delivered and the way healthcare is monitored. My last point is with regard to the cancer incidences, especially within the PMJY. Understanding how critical is this specialty, we are, institutionalizing a dedicated unit within the National Health Authority called the Cancer Cell. This Cancer Cell will be specifically looking at the cancer incidence. Will be and we are already tied up with the Tata Memorial Hospital, the National Cancer Grid. So right now we are developing the standard treatment workflows. At the same time, we are analyzing the type of data especially with regard to the cancer incidences, to understand what type of cancers are prevalent in what geographies. This is going to help us, in multiple ways. Specifically, especially it will help us in devising the preventive campaigns. Right now, we do not have a lot of information. All the campaigns that we do are very generic. This will actually help us that, in this particular geography, the incidence of this cancer is very high. So we need, a particular campaign or particular preventive or a screening campaign which is focused on this type of cancer. So, even we have a lot of focus on, on prevention, on the detection of the cancer, although we are not working directly on it. But, through the data that we are getting, this is our vision. And, I really hope that we are able to probably decrease the cancer incidence rates in years to come.
Thanks, Varun. That's really good to know. I have to rush a little bit because we're running out of time, and I do want to take a few audience questions at least at the end. But I'll quickly just my last question for Sanjay before we move to the audience questions. Sanjay, your technologies and the ones that you have been working on for many years have the potential to improve supply chains. But can you tell us what policy facilitators we still kind of require to bring about better adoption of these technologies? And not only in pharma devices, we mentioned some of that, but it's also the F&B industry, and that's an important determinant of health and of public health. It's a preventive factor. So for the F&B sector as well, and really what are the cost impacts of this? Because if you're talking about adopting technology, is it going to be something that's unaffordable and therefore only for some companies? If you can quickly maybe a few comments so that we don't run out of time before we can take some audience questions. Thanks.
Right. So about the first point, that was the regulation. So presently in India, if you see, we already have a regulation by the Directorate General of Foreign Trade that all the pharmaceuticals that are exported outside India should have some kind of traceability information that needed to be submitted to the government. But if you see inside India, there is no regulation for tracking or tracing the drugs. And I think in the coming days, when the vaccines and medicine for COVID-19 will actually come into the picture, it is going to be very important for all the companies to ensure that counterfeited drugs and spurious drugs do not enter the supply chain, because that would be a very, very bad situation. Because so that is something which I would hope that the regulators would be focusing on in the coming days, to have a regulation in place for tracking and tracing the pharmaceutical products as well as medical devices. Now, about the second point, which was the pricing. The pricing of these technologies has actually been improving from the cost-effective point of view over the past few years. Initially, there were only global, international, European, or maybe American companies who were working on these technologies. And recently, in last few years, we have seen that even many Indian companies have started working on these technologies and started to deliver the intelligent supply chain solution. And that is why even the companies who were global has to review their pricing and make sure they are relevant in India market as well. So as on date, the pricing, I would say, is very, very cost effective if you compare the cost versus benefit of these technologies.
Okay, great. Thanks, Sanjay. That's really useful. I just am now going to a few, so we have quite a number of questions actually that have come in from the audience. I'm just going to get to a few of them because I also have lots of questions left. So I'm going to try and, I think I'm going to be biased towards those questions that are kind of in line with mine, but just to get a few more perspectives here through these questions. So Renuka, Mr. Banerjee, maybe you can take this. Renuka Sharma, one of our students, HCM, wants to ask, would the procurement of medical devices and equipments in the post-COVID era pose a bigger challenge for the hospitals? And is it possible to solve this with the Make in India initiative in a shorter span of time? How can we use Make in India platforms to increase our production?
No, first is, as we say, that we are seeing increased harnessing of the global supply chain. So I don't think that hospital in the near term or even in future has a risk of procuring, as long as the technology is available somewhere. Then the Question comes at what cost? Whether the cost will be high. Second question that comes, what quality they will get. One thing I would like to remind everybody is that manufacturing cost is a function of scale. For anything where scale can be achieved, cost can be brought down. Then comes the quality parameters. So as long as we have technologies which can be in large volume, like something which can be significant in volume, they will be eventually manufactured in India because it will clearly make a business case. But those things which will have a very low global volume, manufacturing in different locations will actually drive the cost upward. So we have to again get back to the point that how do you harness, because it's basically a elementary school decision of make and buy. You make something which you can cost effectively make, and you buy something which you can't make cost effectively. To the point, manufacturing eventually, as long as it can bring down the cost basis the scale, it will happen and it can be sourced. I really don't see any supply chain challenge for any particular technology. Maybe we might have experienced one abrasive data point of ventilators shortfall, because that is never anticipated a pandemic like this, and as a result the global shortfall was there for ventilators, but that cannot be taken as a consistent data point for future. I have not experienced significant shortfall in supplies. For there may be challenges in the supply chain. That doesn't mean that it is difficult to source. That technologies are available, they will be available globally. It can be harnessed by players, all the providers in India. I don't see typically any challenge in that.
Okay, thank you, Mr. Banerjee. This next question, anybody can take this question, but the government spending. This is from Akshita Roth. Government spending on preventive care in India is just 6.8%, according to the National Health Accounts 2017. And nearly 70 to 80% of expenditure is on curative care. Based on speculation, will COVID-19 help bring about a turning point in the myopia with respect to preventive measures? Basically, she's looking at this huge disparity in spending on preventive care and curative care. Which of course has, besides of course the amounts it costs to actually do prevention versus do, clinical treatments. But would any of the panelists like to come in here and respond to this question?
I think I still say that the proportion looks right to me. If you don't prevent, you will find a situation where you can't cure. If you don't stop tobacco consumption, the kind of cancer care, lung cancer and those cases will grow up is huge. So I still believe that if you boost immunity, the chances of coming out of COVID situation is better. So I'm a strong propagator of preventive investment. Of course, we can debate whether it is 70% to 6.5%. But having said that, even now, the solution is going towards vaccination. Solution is not just to continue with the treatment of COVID. So still,
vaccination, some would still argue, is still a for-profit. There's a for-profit motive there. So, when we say preventive care, we're also talking about things that are plain and simple health promotion and other methods. I'm playing devil's advocate here. So, vaccination, there's always been an interest in. Now, of course, it's peaked, more collaborations, fast collaborations, but we're talking about overall preventive health services. And do you think it's something that private sector would ever want to be involved with? Or, or is it something that the government is only going to have to always look at?
No, we do a lot of preventive work. And many pharmaceutical companies in their own domain does a lot of preventive work. And in fact, if those of students who are hearing, it is better to talk about prevention. It brings in better equity, better profiling for the organization instead of talking about just the drugs and the the therapy area that they are working on. I always say that we are there for prevention. If there is a need, we also have medicine. I hope that's from my side.
So I like to add here, it's been like in cancer, a lot of prevention drives. In fact, every month we have one cancer dedicated month, and we do a lot of drives against cancer prevention. For example, in Max, we have dedicated tobacco cessation center with us. Have a dedicated month for, like, for example, October is a breast cancer awareness month. We do free mammograms that month. We also do a lot of camps in the nearby areas, have associations with RWAs, do screening for cervical cancer. So actually, for cancer, if we just see, we play a huge role in not only spreading awareness about cancer, but also do screening for cancer, especially for tobacco-related cancers, for cervical cancer and breast cancer.
Right, right.
Yeah,
Thank
let
you,
me
Doctor.
just give a very quick remark.
Sure.
I think it's not only the financial hurdle, but more than that, I think it's the lack of information. If you look, and let me attest this point by the evidence that if you look at a lot of states, there is such a huge amount of money which is unspent in the NHM budgets, huge, by a good 65-70%. And I'm talking about states which have relatively better health outcomes. Now, what really happens is that when we talk about the preventive campaigns, we are only looking more at the IEC level campaigns that will create awareness, and probably we will all organize probably camps and we'll do screenings. But I think the real focus needs to be on creating proper data structures wherein you also identify the high risk individuals and you keep constantly following up on them. So I think that itself is more of the smart prevention method that we need to adopt, and a lot of countries have actually done that, and they have been fairly successful. I think once we know that this is the type of scope of work that we are looking at, the financial percentage which is allocated to prevention, it will automatically shoot up in years to come.
Okay. Yeah, that's really important. You're right about the smart prevention and focus strategies going beyond IECS. I think that's really important because we tend to leave prevention at IEC, DCC, and
I have a comment here actually. See, first is we should not look at only percentage spent on prevention to say that prevention is not being focused on. Prevention actually is a responsibility for every stakeholders in the ecosystem. Be it the payer, need to create awareness so that their health bills are lower. Providers really want to keep the patient away. It is not that they make a lot of money by keeping the patient in the hospital. They make money by treating them, but definitely not making money by keeping them in the hospital. Third is, if you look at government also can spend make investment on awareness. But first comes the responsibility of the patient to create a healthy mindset. So as long as the patient themselves own the responsibility, in fact, there is a big change that happens when you look at an insurance policy where it is fully paid by the insurers. The level of awareness on or the intent on prevention is much lower to an insurance policy where there is a co-payment option. The moment you ask the patient to pay, there's a little more sensitivity towards health. So I think it's a responsibility of all stakeholders in the ecosystem, not just government or any one segment.
Sure. Definitely, I think.
Allow me to.
Yes,
allow me
quickly.
to add a comment here.
Yeah,
about this. If we see in the last few years, the preventive healthcare market in India is growing at the rate of more than 18 to 20%. So there is actually a curve which we can see that awareness about preventive is growing. And in fact, it is also estimated that the preventive healthcare market by 2022 in India will be $100 billion. So there's no doubt that the private sector is going to focus on preventive healthcare market. And I assume that the government sector will also take this very seriously.
Sure. Thanks, Sanjay. Thank you for that. Because we're running out of time, there are a lot of other good questions. I'm going to incorporate one of the questions from Mr. Anjan Bose, which is, the top learnings and integrate that into your closing remarks. So if each of you could just maybe just highlight the top one. He's asked for 3, but we don't have time for 3. So, the top one learning for your sector from this, which can be taken forward for improving health systems going ahead. We can start with, maybe in the same order that we began, Dr. Rajpurohit.
I think the learning which has been through this session with all the authorities to speak together, and that has been that actually we need to partner more. We need to understand what are the challenges and how together we can overcome them. And I think that there needs to be more participation of the private sector. We have to have such kind of discussions with the government officials as well as the other key stakeholders, so that we can achieve a better health outcomes both in the private as well as in the government sector.
Thank you, Dr. Sachin. Mr. Manoj?
I think this COVID taught us how to go back to roots, how to really understand what is our priority in life, and what is the difference between need, want, and desire. We also realize the importance of digitalization and how important it is in our life. The very webinar that we are doing, clearly we have taken us at least 1 year to organize as a face-to-face meeting. So we realize that if we are proactive, we still can. I'm sure we will one day talk about the situation that we have said, Corona go. It has already left the world.
Okay, thanks, Mr. Kumar. Mr. Banerjee?
Yeah, so if you really ask me, although there are few learnings, but I'll just focus on one because Anjanda asked you to focus on one. So
he asked for three actually, so
yeah,
I've kept it.
Yeah, so I'll keep it one. The first biggest learning that we get to sense, especially I would talk about the super specialty. I think one thing that has been exposed for the super specialty is that we have over dependence on the metropolitan city as far as tertiary care is concerned. So the tertiary care now really need to move to tier 2 cities, and that can only happen if there is significant investment on skill development for the surgeons and the supporting healthcare staff, because medical device per se, the safety and efficacy depends on the implantation skill because it's an engineering product. Second thing is that availability and strengthening the supply chain in the tier 2 and tier 3 city. So this is the biggest learning, and we need to somewhere, create a better distribution of care across cities rather than kind of focusing only on the metropolitan cities or the large cities.
Sure. Thank
in
you.
A way, eliminating
Sanjay?
geographic access barrier, I would say.
So
eliminating the geographic access barrier.
So in my opinion, the biggest learning is the need for visibility of supply chain for pharmaceuticals as well as medical devices. That could be achieved only by connecting our supply chains nationally as well as globally.
Okay. Thanks, Sanjay. Sachin?
So what I think the biggest learning in terms of technology, people are actually advancing a lot. Like if I am telling you like 5,000% the virtual rate is increased, where like 80% of users are actually first time use the virtual care, out of which 44% are actually from the rural area. So that is the kind of advancement in terms of technology, actually creating a lot of value. Second, I just want to quote, it's very important, like we can see those countries have policy-based strategic relationship with the private sector, seem to have performed well in controlling this pandemic. Instead of arm tweeting the private sector, there is need to formulate a stable policy-based strategy to get the private sector on board. If we take example of US, the government regulatory body CMS waived off Medicare charges, HIPAA compliance on telehealth uses to deliver better healthcare outcomes. So it's very important how basically we are coming like a policy-based strategic relationship strongly between government and private sector.
Right. Thank you. Thanks, Sachin. Varun?
Well, I would say that this has been probably a wake-up call to probably not look at health systems in silos, but more of a comprehensive picture. Not just looking at primary care or tertiary care, but probably looking at the entire continuum of care. At the same time, probably leveraging technology as a lever, to actually make sure that the entire system can come together and enable some sort of a strengthening of the system. And finally, one thing that we have always been looking is that, either it is a private system or a public system, but I think one thing that we have realized is that there needs to be a very good synergy between both these stakeholders to actually strengthen the type of health ecosystem that we are envisioning for 135 crore Indians. I don't think so. Only the government or only the private sector can do, and we have seen the private-public partnerships working and flourishing in other sectors also. I think it's high time that we adopt similar sort of an engagement between the public and private sector, and we look at the entire health ecosystem. And I think if we probably start doing that, then probably we will be much better prepared for the next pandemic to come.
Right. Thank you, Varun. I think that's kind of how I would look at closing it. That it's about a health system, and like I said, the goals are common. A health system can have only one set of goals, and that's improved health of the population, financial protection in doing this, and the third is responsiveness or customer satisfaction. So I think these are goals that all of the stakeholders of the system, if we all look at these as common goals, we would be pushing the system forward significantly in our own way. So thank you very, very much to all the panelists. We've actually overshot by 15 minutes, but I really couldn't stop because I felt like we hadn't hadn't completed it. There's a lot more that we could discuss, and it would have been nice to continue, but I have to bring this to a close. So thank you very much to all the audience. I hope that in today's discussions, irrespective of our place within the health system, where we were able to identify and appreciate issues of its capacity, resilience, and sustainability. We have seen areas of strength with successful partnerships, and we've also seen areas of weakness where sustained efforts are required at building bridges where we have to. Future novel disease outbreaks with pandemic potential are a certainty. However, these challenges must be addressed going ahead in order to also deal with the multiple existing public health issues so that we can move the Indian health system forward and push for better population health as a whole. So I thank all our esteemed panelists for giving us their time today and providing important insights into the theme of our discussion. I thank our director of the Goa Institute of Management, Dr. Ajit Parulekar, for supporting this initiative. My healthcare management student teams at GIM and the Intas team and Mr. Kumar for also being a part of this, and all of you for taking the initiative and putting together this webinar to the students who really wanted this. Thank you to all of you. And finally, I thank each and every one of you who have contributed with your questions, with your participation and listening in. I really hope this was useful to you. A recording of this webinar will be made available on our GIM YouTube channel. We look forward to a continued engagement with all of you. Have a good evening and a great weekend. Thank you very, very much.
Thank you.
Thank you, Kia.
Thank you all.
Thank you.
Thank you, Kia.